So moving on to the next part in the chart on psychotherapies is the humanistic perspective. And so what I have on my chart underneath humanistic is just really important. You've got to write Carl Rogers' name. He is the humanistic therapist, essentially. So the aims column, it's the aim of humanistic therapy is to boost self-fulfillment by helping people grow in self-awareness and self-acceptance. I have exactly that written on my paper. Really, really important. And then again, just a reminder, the buzzwords here being it's all about the self, right? Self-awareness, self-acceptance, and having a good understanding of those things. Under the methods used, we've got client-centered therapy, also known as non-directive therapy. You have that on your paper, so make sure you highlight that it's also called that, just in case they decide to call it that on the test. It's also called person-centered therapy, what we have up on the slide here. Again, developed by Carl Rogers, and it's the client-centered therapy where the therapist just listens to the needs of the patient in an accepting, non-judgmental way, addressing the problems in a productive way, but by building his or her own self-esteem. So as it says on the paper, the therapist listens and lets the client gain insights on their own. You might want to clarify this in your mind by writing down a few things that really the most the therapist does is listens, and then with the active listening part, they echo, restate, and clarify the patient's thinking. They don't say, here's what I think. They don't say, here's what you should do, here's what's wrong. All they do is echo, restate, and clarify through active listening. So they might say to the patient, so what I hear you saying is da 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 da, and they restate what the client has just said. The idea here is for the patient to do essentially the work in the therapy session, but that's kind of the beauty in this type of therapy. The client themselves is able to come to their own conclusions and their own therapy with the active listening and guidance of the therapist. So in the third column, the therapist is to be empathetic, meaning have empathy, to feel for the client, accepting and genuine, play that accepting person, that role in that person's life that they might not otherwise have. The next one is behavioral. You might want to also put that this is learning, right? The behavioral therapy, it applies learning principles to the elimination of unwanted behaviors. So what I have on the chart, and you might want to really listen here and pause and rewind me if you need to, is to change maladaptive behaviors and replace with appropriate behaviors. So in the aims column next to behavioral, to change maladaptive behaviors and replace with appropriate behaviors. You could also make a note that behavior therapy is what is used to treat most anxiety disorders, so phobias, OCD, anxiety, etc. So let's talk about the methods used. There are two different kinds of techniques, essentially, one classical conditioning, one operant conditioning. What you should do next to systematic, exposure, and aversive conditioning is do a little parenthetical thing there and say that these are classical, or CC, classical conditioning techniques. They're all essentially counter conditioning, you could say. Counter conditioning being a procedure that conditions new responses to the stimuli that triggers the unwanted behavior. So you're taught a new response to a snake when you cry like a 4-year-old girl and get into the fetal position when you see a snake. That's an example. Again, it's based on classical conditioning. It includes exposure therapy, aversive conditioning, and systematic desensitization. So exposure therapy, as we have on our paper, present stimuli until no longer have anxiety toward it. It's simply that. You expose the patient to their fear. They eventually learn, oh, I'm not going to die, or wow, this isn't so bad. So you're afraid of snakes? Here, hold a snake. That's exposure therapy. Systematic desensitization, you should make a note here, is a type of exposure therapy, but it's a little more complex. So you associate a pleasant, relaxed state with the anxiety-producing stimuli by being exposed to it. Okay, so you associate happy thoughts, deep breathing, Again, thinking pleasant things with gradually increasing exposure to the anxiety triggering stimuli. So you need to write down that you take baby steps. You're afraid of snakes? Here's a picture of a snake. Breathe deeply, think happy thoughts. Here's an actual snake in a cage in the same room as you. Do the same thing. Now here, hold the snake, right? Baby steps working up to it's not that bad, associating it with a relaxed state. Aversive conditioning, what you're trying to do is get rid of an unwanted behavior. So this is the smoking, the nail biting, the cursing, drugs, alcohol, any of that thing, where you would associate something yucky. So nail biting, you put that nasty nail polish on your nails. Ugh, it tastes bad. You don't want to do it anymore. With drinking, you put something in the drink that makes the person feel nauseous. Now, operant conditioning principles are used in what's called token economy, which you have on your paper. It's important to note that these are used in an institutional setting, so in a psych ward, in a mental institution, where they reinforce behavior, the desired behavior, with a meaningless token, for instance, that can be redeemed for something meaningful. So just like going to Dave & Buster's or GameStop or whatever, earning your tickets, earning your tokens, and you exchange it for the biggest and baddest slinky of all time, right? But it's for more adult-like things, like some kind of privilege within the mental institution.